ESMO 2025 was truly mind-blowing. I don't think we've ever covered so many abstracts in our conference highlights episodes, but this year's ESMO, and particularly breast cancer section, definitely demands it. And Rahul, that's what we were talking about before we jumped on this discussion. Every day at ESMO brought more practice-changing and
Mm.
practice-informing updates. Hello, everyone. Welcome back to the Oncology Brothers podcast. I'm Rohit Gosain, alongside my brother and co-host Rahul Gosain. Our job today is to break down the most impactful studies in breast cancer for all of you in the community practice. To help us unpack the breast cancer data, we are welcoming Dr. Virginia Kaklamani from UT San Antonio. Virginia, it's great to have you back, ma'am.
Oh, thank you both for having me. I was waiting for this to just look at the data one more time to try to figure out what to do in my practice as well. This could be confusing.
Wow, there's a lot. Virginia, welcome. We have little time, but we have close to 8 abstracts to touch on. Starting off with early stage hormone receptor positive disease, where we have MonarchE trial now showing overall survival benefit. We'll then switch gears to metastatic space and touch on our new estrogen receptor degraders. Then in HER2 space, we have quite a few destiny trials to touch on. And to close, in triple negative disease, we have 2 competing ADCs. Let's start off with MonarchE study, where we have abemaciclib in early stage breast cancer. Abemaciclib was initially approved in 2021, and this was based off MonarchE study showing invasive disease-free survival. In this study, patients included were N1 disease along with high-risk features or N2 disease. Abemaciclib is for 150 milligrams twice a day for 2 years. Here at ESMO 2025, we saw more mature data, and now we have overall survival benefit. Virginia, can you touch on this study and its findings?
Yeah, so this is important when you look at the absolute difference in overall survival, 1.8 months. It's probably not what people would expect, but the bottom line is that we finally have survival benefit in the adjuvant setting, which is huge.
Yeah.
We haven't had it before. Just a reminder, we never saw survival benefit in aromatase inhibitors versus tamoxifen. So this is really big, and it solidifies the fact that for high-risk patients, we should be using a CDK4/6 inhibitor in the adjuvant setting.
It is important to stress that this difference is rather 2%, which seems small, but again, keeping in mind that this is an adjuvant setting, which is hormone receptor positive space, it can take some long-term data to even solidify this. What we are seeing here, which is important, at that the curve continues to stay separated. Now, moving along into discussing our another CDK4/6 inhibitor, what we saw from NATALEE trial with ribociclib is that here the invasive disease-free survival curves continue to stay separated, but we are still waiting on mature overall survival data. Adjuvant ribociclib is for 3 years, while abemaciclib is for 2 years.
Virginia, before we move on, here we're left with cross-trial comparisons. In your clinic today, who gets abemaciclib versus ribociclib, and any clinical pearls around dose optimizations or management for diarrhea?
Yeah, absolutely. So the MonarchE has more mature data. It has 7-year data versus 5-year data with NATALEE. It's also 2 years versus 3. So I typically, for my higher risk patients that meet MonarchE criteria, I use abemaciclib. I usually do my dose escalation. There was data presented at ASCO looking at the dose escalation and having a lower rate of diarrhea. Practically, you have to think of how you're going to do that dose escalation. And the trial was done looking at 50, then 100, then 150 every week or two. It's going to be hard because of how the prescriptions are given. And
Yeah.
so I typically will give 100 and then try to go up to 150 after 1 month of therapy. Patients seem to tolerate that well. And the ones that do not, I will switch to ribociclib and give 3 years of therapy per NATALEE. Now, the patients that have node negative disease that do not qualify for MonarchE are going to get ribociclib per
Absolutely.
NATALEE. In my mind, it's been pretty solidified. And with all of this data update, it just reiterates the fact that we should discuss CDKs for these higher risk patients.
Yes, diarrhea is a concern, but if managed proactively, one can have a better course with these supportive regimens. And also keeping in mind that one sees diarrhea as a concern for the first month, and that does improve subsequently after that. Okay, moving along to our metastatic hormone receptor positive disease. At the time of progression on CDK4/6 inhibitors, it is important to check for ESR1 and PIK3CA mutation, as we have few options available here. At ESMO 2025, we saw data around VIKTORIA1 in PIK3CA wild type, but also it did include PIK3CA mutated population as well. What we have here is Gedatolisib, which is an IV drug, and it was studied in triplet with palbo and fulvestrant, but we also saw data as a doublet as well. Virginia, your thoughts around the study?
So this study it was two studies. The one study looking at the PIK3CA wild type, the second one, which we still are going to wait for results because of some statistical considerations, is the mutated subset. So the Gedatolisib is a winner. That's the bottom line. Problem is that it is IV. The problem is that it can cause stomatitis. We had 60 to 70% stomatitis, including around 12 to 20% grade 3 stomatitis. Now, having said that, we use steroidal mouthwash for these agents, and this was not mandated on the trial. I would assume that if we did use that, the rate of stomatitis would be lower. But this is a drug that, based on the PFS, we'd be using it for 9 months plus. And so it's important for us to consider the fact that we would have to use a steroidal mouthwash. This is really a big difference in the PFS. People can say that the control arm was suboptimal with fulvestrant. Absolutely, completely agree. Dr. Hurwitz, who presented the data, said that the FDA told them to use that as a baseline standard of care. But this is really a big difference. And a hazard ratio of 0.24. I don't think we've seen this before. Even in the HER2 positive patient population. Really good data, and I expect this agent to be approved. We'll see what the mutated patient subset shows, but I expect us to be using this in the future.
I think on our end, three things. You touched on two of those already. One, that control arm of fulvestrant, not a true reflection of what we are often doing in our clinical practice. Second, bringing patients in weekly IV treatment is also cumbersome. Third, stomatitis or mucositis. This is something we're starting to see more and more. Dato-DXd has the side effect. Of course, everolimus, which got us to use more steroid mouthwash, is something that we have to keep in mind as well. This is actually a good segue to our next study, evERA trial, where we have an oral SERD with everolimus. And here the control arm was a little more reflective of what we do in our clinic, endocrine therapy with everolimus. This is also in patients that have progressed on that first-line CDK4/6 inhibitor and endocrine therapy. We're seeing significant improvement in PFS with Giredestrant and everolimus combination. Virginia, what can we walk away with for this study?
I like this study exactly for what you said. The standard of care arm does reflect what we do in clinic. And so a hazard ratio of 0.38 is really impactful. The bottom line for this trial is Giredestrant is an oral SERD that is active in tumors that have ESR1 mutations. In combination with everolimus, I expect it to be used in that second-line setting in the non-PIK3CA patient population. It'll compete with the Gedatolisib. We just saw the data there, right. So we'll see what we're going to do. I think in that ESR1 mutated patient population, the combination of Giredestrant and everolimus seems very promising.
Virginia, I'm back to cross-trial comparisons again, because soon we'll have multiple SERDs available to us. How are you picking one over the other, combinations versus single agent? What are you going to do once this is all available for us and our patients?
I think we're going to have to pick based on the disease risk and the patient we have in front of us. I like single agents because they're so well tolerated. And I always tell my patients, this is a marathon, not a sprint. If I cause 60% stomatitis with my second line therapy, that may be prohibitive in how I'm going to treat them in the third and fourth line, especially when these ADCs come up. And one of them does cause more stomatitis. So we have to be a little careful. So the patient that is on the CDK4/6 inhibitor has a long disease or progression-free interval, is doing really well. Her tumor has developed an ESR1 mutation. I'd be very happy giving single agent, either elacestrant or imlunestrant. Maybe adding everolimus and Giredestrant to that mix might be okay as well. We've already seen, and we're going to see more data with combinations of both imlunestrant and elacestrant. But I like my single agent there. And the patients that have a little bit more impact of their disease, maybe more symptomatic disease, I potentially see Gedatolisib being used, or the combinations here of Giredestrant and everolimus. This is going to be very hard. We have SERENA-6, where we potentially may be giving the oral SERD while the patient is on the CDK4/6 inhibitor. Okay. We'll soon see results from SERENA-4, which is our first line oral SERD plus CDK4/6 inhibitor, we may be using these agents in the first line. The
Absolutely.
field is evolving so quickly that it's very hard to keep up.
Right.
And secondly, what we're talking now may be totally irrelevant when these agents are approved and there's more clinical trial data to look at.
This is a good problem to have because our patients are indeed living longer because of this.
Right, talking about that itself, the oral SERDs like Giredestrant, I do think that adapting this oral single agent would be my preference. Now, switching gears to the HER2 positive space, where TDXd is being treated in every aspect of HER2 positive disease. At ESMO, we saw neoadjuvant TDXd plus THP for T3 and above, or N1 disease and above. This was based off of Destiny Breast 11 trial. What we also saw was from Destiny Breast 05 trial, that is TDXd over TDM1 being used in adjuvant setting for high-risk residual patients, that is lymph node positive or inoperable disease. Virginia, before we dive into Destiny Breast 05, if you could please touch on Destiny Breast 11 and then Destiny Breast 05, and how do you plan to use this in your clinic today?
I think this is the most confusing part of what we just saw at ESMO, trying to decide, should we use TDXd in the neoadjuvant or adjuvant setting?
Definitely.
Both studies are for higher risk patients, and we have to
Right.
recognize that. TDXd here was given for 4 cycles. And just as a reminder, the TDXd only arm actually did not perform better than the standard of care. So that was not really presented. So we're kind of left with TDXd for 4 cycles followed by THP as possibly the new standard of care in the neoadjuvant setting. Low rate of ILD, only 4.4%. Interestingly, the standard of care arm had a 5.1% ILD, which tells me that it was probably the screening during the trial that identified some of that subclinical ILD. This is a nice regimen, and it's only 4 cycles of TDXd with low toxicity. Many of our colleagues are going to be using that. I still have to figure out whether to use this approach in Destiny Breast 11 or the 14 cycles in Destiny Breast 05. I had a patient in clinic yesterday, 38 years old. She had TCHB, had residual disease. She was node positive initially. And so I talked to her about this and about TDM1. I'm conflicted as to what to do. This is the first time we've seen this data, but at the same time, a 38-year-old needs at least a conversation about this new clinical trial. So here in Destiny Breast 05, patients that have received neoadjuvant chemotherapy, they, as you mentioned, had high-risk disease to begin with or node-positive disease at the time of surgery. And then they were randomized to TDM1 or TDXd. The reason that this high-risk patient population was selected was because in KATHERINE, we saw that those were the patients that had a higher risk of recurrence. And so the results showed an improvement in IDFS. Again, the hazard ratio of 0.47, which I think is very clinically meaningful. And
All right.
something else that was interesting in this trial, and we had not been able to achieve with KATHERINE, was a decrease in CNS recurrence or metastasis. In KATHERINE, it was a positive trial all around. The one subset
Absolutely.
that did not seem to benefit from TDM1 was emergence of CNS disease. Here we saw a decrease, at least a numerical decrease. It means 14 cycles of TDXd. It also means an increase in the rate of ILD. And so here the rate of ILD was around 10%, 9.6 or so, and 2 fatalities. This is something that we all need to be careful because this is the curative setting. And if we're going to use this regimen, we have to use it in patients that have higher risk disease. Also, the monitoring of ILD is a little bit different. We initially do it at 6 weeks, but then we go to 9 weeks. There's also different monitoring if patients were getting sequential TDXd after radiation or concurrently with the radiation. But interestingly, and we'll see some more data coming up soon, but the radiation didn't seem to change the rate of ILD. So whether you do radiation together with TDXd or whether you do the radiation first and then you start TDXd didn't seem to affect the rate of ILD.
Thanks so much, Virginia. With HER2 positive or triple negative, we tend to see that CNS
Yeah.
occurrence, and something to keep in mind. I do want to reiterate the concern of ILD in neoadjuvant setting, even for Destiny Breast 11, though we did see low ILD, but keeping in mind that these patients are so closely monitored in clinical trial setting, while in real world, these things are going to be a lot different. We are not getting scans every 6 weeks. So when utilizing this agent, ILD is a severe concern and needs to be monitored closely. All right, before moving on to the triple negative breast cancer space, for HER2 metastatic breast cancer, we saw an update from DB09 with TDXd plus pertuzumab in frontline setting. So far, the standard has been THP, where we drop the chemo and continue on with the HP for a long period of time. Keeping someone on TDXd for 2 to 3 years seems a bit much there. Thoughts on Destiny Breast 09, and have you started offering this to your patients yet?
So I think again, pivotal trial. It's important that to note that the arm reported was TDXd plus pertuzumab. We're still
Yep.
waiting for the TDXd plus placebo arm,
Right.
which I think is going to be interesting as well. Giving TDXd plus pertuzumab for that long is really hard for patients. I would love to do this for my first 6 or so months to maximum disease response, then use some maintenance therapy. And we have a couple of actually, we have the Patina trial that looks at
Yes.
CDK4/6
Right.
inhibition plus endocrine therapy in the ER positives. And we're soon going to have other data looking at maintenance therapy in those patients that may not have HR positive disease that I think we may want to utilize. So I think it's a winner. I think if I see somebody that has now been diagnosed with metastatic disease, I would be doing this combination. But at the same time, I'd like to use a maintenance approach. I don't think it's feasible for most of our patients to use this for such a long time.
Virginia, when we're talking about maintenance, are you stopping TDXd and then adding trastuzumab and continuing with pertuzumab or single agent anti-HER2 here?
So I would usually do trastuzumab, pertuzumab, CDK plus aromatase
And that's
inhibitor,
it. Yep.
exactly how the
Okay.
Patina.
It was done. Perfect. Okay. And TDXd has been the big one that has made splash when it comes to antibody drug conjugate. But this is not the only ADC that's approved here for breast cancer. We also have sacituzumab targeting TROP2. Now we also have Dato-DXd, which is approved in hormone receptor positive disease based off PFS, but there was no OS there. This takes me to triple negative disease. And at ESMO, we saw data on ASCENT-03 trial with sacituzumab upfront versus chemotherapy in patients that were not immunotherapy eligible. This trial did allow crossover. Virginia, your take here on ASCENT-03.
Absolutely. And this is coming together with ASCENT-04 that was presented at ASCO, which was the exact
Yes.
same trial, but with immunotherapy and
Immunotherapy.
immunotherapy eligible patients. Similar results there, an improvement that was statistically significant in PFS. We saw the same thing here. The fact that they allowed crossover is exceptional for this trial, and the company needs to be congratulated for that because this is what's serving our patients. So I did
Absolutely.
not expect to see an overall survival benefit. Obviously, the results are immature, so we may see something in the future. But a pretty large number of patients on the trial did cross over to receive sacituzumab after disease progression. So this is a winner. I've moved my ADCs into the first line setting in triple negative breast cancer since the ASCENT-04 presentation and the press release of 03. And I think we should be considering doing that now and definitely when these drugs get approved in the first line setting.
Okay, moving along from one ADC to another ADC. Here, what we see is TROPION Breast 02, where we saw data from Dato-DXd. Virginia, if both sacituzumab and Dato-DXd were to become available, how are you sequencing this?
Yes. So, likely because of this trial and the overall survival benefit, as well as the PFS, this did not include a crossover, which is probably why the OS was significant. I would expect that people will decide which one is their favorite ADC and use that. And really, the way to do that is going to be toxicities and schedule. This is a Q3 week ADC, so easier than giving day 1, day 8 of a 21-day
Yep.
cycle, which is what we do with SG. At the same time, SG is going to have cytopenias. On the trial, they did not use prophylactic GCSF, which was a shame because we do use that in clinic.
Yep.
There's some diarrhea with sacituzumab as well, which in my practice is very manageable. When we look at Dato-DXd, we're thinking stomatitis, keratitis as well, which is something we have to be careful with. So there's ways to deal with the stomatitis. Use ice chips while patients are getting the infusion, and also use a steroidal mouthwash, which has to be given 4 times a day. So not the easiest thing in the world. For the keratitis, people are suggesting cold compresses while patients are receiving the treatment, and eye drops that are being given, and seeing an ophthalmologist. So the bottom line, it's really hard to pick between these two agents, but both of them are going to be used in the first line setting, which is huge for our patients.
Indeed. Thanks so much for covering that. I just want to reiterate, at least for the community oncologists, where side effect profile is why we sometimes are hesitant in utilizing some of these therapies, partnering up, at least for Dato-DXd with ophthalmologists, given the ocular side effects you mentioned. But also there is a small risk of ILD that we should be aware about with sacituzumab, neutropenia, fatigue, alopecia, and diarrhea. Before we close, Virginia, any final thoughts on any other studies that caught your attention, at least from community oncology standpoint, that you'd want us to know?
Yeah, so we're learning how to deal with adverse events and ILD, and this is really kind of our the more we use TDXd, the more we're learning. And so what I've started doing in clinic is identifying patients that have a higher risk for ILD. It's not easy to be doing scans every 6 weeks. I write in my notes that these patients need more monitoring. The majority of the patients will not. And so I think this way is going to be a little bit easier in treating patients because TDXd is everywhere. We're using it in HER2 low, HER2 ultra low, triple HER2 positive disease, and we really need to know how to use it safely. So really good data, very impactful. All of these trials are likely going to lead to FDA approvals of either new medications or new indications. This is really exciting.
Virginia, this was phenomenal. Thank you so much for walking us through such a data-heavy ESMO. Before we wrap up, for our listeners, let's do a quick recap. In this discussion with Dr. Virginia Kaklamani, a breast medical oncologist, we had a chance to touch on some key breast cancer studies from ESMO 2025. We now have overall survival benefit with adjuvant abemaciclib for high-risk, early-stage hormone receptor breast cancer. We also have quite a few SERDs being studied, especially with combinations rather than monotherapy. In EVERA trial, we saw that Giredestrant with everolimus improved median progression-free survival when compared to everolimus with endocrine therapy. For HER2 disease, the DESTINY trials absolutely stole the show. DESTINY-05 boosting adjuvant disease-free survival, DESTINY-Breast09 showing strong first-line efficacy in metastatic disease, and DESTINY-Breast11 showing significant if used in neoadjuvant settings.
And in triple-negative breast cancer, ASCENT-03 expanded sacituzumab's role to the front line, where TROPION-Breast02 added Dato-DXd as another viable antibody-drug conjugate in the toolbox. Such an incredible lineup. It's hard to believe all this came from one meeting, that is ESMO 2025. Thanks so much for joining us. We look forward to seeing you in person at SABCS 2025. We are the Oncology Brothers.